Recording in progress.
So, good evening, everyone. On behalf of Genova, I, Dr. Preeti Gasbe, and I extend a warm welcome to all of you in this dynamic international speaker symposium. So, the objective of today's meeting is to establish the sucralfate oxyhydroxide as a first-line therapy in the hyperphosphatemia, which is already supported by the robust global clinical evidence. Also, to present the real-world data of this clinical experience, real-world data and the clinical experience with the use of the SO in clinical practice. So this is the agenda. So the welcome note followed by the introduction remark by the Dr. Tarun Jaloka sir, and there will be a presentation by Professor Floch on the sucralfate oxyhydroxide, a novel phosphate binder as a first-line therapy, and followed by the panel discussion and the take-home message. So we are honored to have our moderator as Dr. Tarun Jaloka sir. So, sir is a senior consultant in nephrology and renal transplant at Manipal Hospital, Baner, Pune. Sir is a member of the Scientific Committee of Indian Society of Nephrology, then council member of the Indian Society of the West Zone 2016. Sir is also a joint secretary for the Indian Society of Peritoneal Dialysis from 2012 to 2016. Also a secretary for the National Academy of Medical Sciences from 17 to 18. Sir has achieved lots of awards and achievements. So one of the awards, there's a PM Verghese Award for the most compassionate of the junior resident, then a global medal DNB nephrology, then Bansal Oration Award, Excellence in Nephrology, then the Dronacharya Award for the CME Excellence. So along with the several best paper and poster award at the national conferences. Sir has a more than 15 publication and he has participated as a principal investigator for the new product clinical trial. So with this, so please join me in welcoming Dr. Tarun Jaloka, sir, to guide us through today's discussion. So over to you, sir.
Thank you so much, Preeti, and thank you, Genova, for having me here. So we all know that phosphorus is an integral and important part of mineral and bone disorders associated with chronic kidney disease. And hyperphosphatemia itself is independently associated with increased morbidity and mortality in these patients. Now, what I know is Professor Jürgen Floch is the best person who knows bone in CKD better than Professor Jürgen. Because I remember we have been reading his research articles for last 20, 25 years, even when I was doing my fellowship in nephrology. So he's the best person to tell us about the nuances of phosphate control. Because despite knowing the treatment of phosphorus control, a significant percentage of our CKD patients still remain to be hyperphosphatemic. So Professor Jürgen Floch is a senior professor, Division of Nephrology and Immunology at RWTH Aachen University in Germany. He has got several laurels to his name. He's co-editor of leading textbook of comprehensive clinical nephrology. He's editor-in-chief of CKJ. He's associate editor of KI, and has got 800 plus scientific papers. So what we'll do is, after introducing the speaker and the panelist, we'll straight away go to Professor for his talk. And after that, whatever time remains, we will indulge in panel discussion for our day-to-day practical approach to control of hyperphosphatemia. Our other panelists are Professor Rajesh Nair. He's head of nephrology and kidney transplant services at Amruta Institute of Medical Sciences, Kochi, Kerala. And the other panelist is Professor Jayantu Datta, who is in Maniktala, West Bengal, and he is attached to several other hospitals. So without wasting any time, let's move on to Professor to hear him about the nuances of phosphate control in CKD patients. Over to you, Professor.
Thank you very much, and good evening, everybody. Let me just share my screen, and we can take it from there. All right. My name is Jürgen Flöger. I'm from this funny hospital here. And the really interesting thing about this is that the trees you see in the background, that's another country. That is Netherlands. And if you were to look here, you would look at Belgium. So just a very quick introduction. I'm from Aachen. Aachen is in the very center of Europe. In all likelihood, you never heard about this, but it's the most important city in German history because this is where Germany was founded in the year 800. And this octagon here at its time in the year 800 was the highest building north of the Alp Mountains. So it's a very historic city. It's very well known for its technical university. And I truly enjoy living in the center of Europe. Now, switching to CKD, MBD, and hyperphosphatemia. Take-home message number one, serum phosphate predicts all-cause and cardiovascular mortality in CKD patients. This has already been mentioned, but don't forget, this is an association. There's also an association between being in bed and dying. Despite that very strong association, I will go to bed tonight. Just illustrating that associations can be highly misleading and we need better proof. This is a little bit better proof. What we have done in this study is we looked at dialysis patients where the baseline phosphate was well controlled. And then we looked what would happen to their hazard ratio to mortality if the phosphate decreased, mortality increased. If in the next month the phosphate increased, mortality increased. But this is truly the most important. So if you have a dialysis patient with hyperphosphatemia and phosphate increases further, so does mortality. But if it decreases, you see this very interesting dip here where mortality decreases by about 20% if you manage to decrease phosphorus by 1 milligrams per deciliter. It's one of the few, and I'm really sorry to say that in the year 2025, we still have no firm evidence that reducing phosphate is a good thing, but we certainly have a lot of associative evidence for that. Take-home message number two, phosphate additives in food affect lab parameters and bones, at least in mice. Here are 10 healthy volunteers, humans, given 1 week 900 milligrams of phosphate and 1 week a diet containing mostly processed food, but the same calories and same composition. And what you see is, if you look at this, if you eat mostly processed food, you have a 60% higher phosphate intake. And by the way, sodium intake is almost twice as high. So very clearly, there's an emphasis for these patients to stay away from processed or ultra-processed foods. And it's a very ironic scheme that the University of Michigan made, where they say the following items from McDonald's contain phosphate additives. Avoid menu items that consist of these foods. And essentially it comes down that you can eat the menu, but don't eat the food. And this clearly is one of the big problems of modern civilization, that we have these many, many phosphate additives in whatever food. Take-home message number three, high serum phosphate markedly accelerates calcification, in particular, if there are other procalcific factors. Let me show you why. First of all, we have learned that as early as CKD 3 and 4, patients tend to have a positive calcium balance. So this is a control person given a low calcium diet. This is a control person given a 2000 milligram elemental calcium diet. And you can see that this person is in a positive balance. The net balance is 500 milligrams per day added. This person is even in a slightly negative balance. If you then look at CKD, the opposite, the totally different thing happens. If you are on an 800 milligram calcium diet, you're just about neutral, but this almost doubles. So the take home from this is that even early CKD 3 and 4 is a state of calcium accumulation. we also know that something happens in the vessel. This is a beautiful study of Roxana Schroff from the Great Ormond Street in London, the Children's Hospital, and they took out arteries of young dialysis patients, and they put them in the arterial vessel rings. They put them in a medium containing 2 millimoles of phosphate and 1.8 millimoles of calcium. If you do that with normal arteries of children, nothing happens. Even after 21 days, hardly any calcium in the vessel wall. But look at this, pre-dialysis kids, quite a dramatic accumulation. Dialyzed children, massive calcium accumulation in the vascular wall. So there's an intrinsic propensity of the vascular wall to suck up calcium, and this is related to apoptosis and other changes in the vascular wall. And then Dr. Ok from Turkey did this interesting study where he dialyzed patients against a bath containing 1.25 calcium, which I guess is normal for most of us nowadays. But when I was a junior fellow, the normal calcium in the dialysate was 1.75. 2 years later, he measured the coronary artery calcification score. He was deeply frustrated because, yes, there was a trend towards more, but it wasn't massive and there was significant overlap. Same if he stratified for controlled or uncontrolled hyperphosphatemia. No real significant difference. But then he did the telling thing. He added the two together. So if you have uncontrolled hyperphosphatemia and you're dialyzed against a high calcium bath, you add from 180 to almost 500 score points in 2 years. And just to put that into perspective, when you and I turn 80 or maybe 90 years old, we may have a total coronary artery calcification score of 500. We're really calcified then. Here, if you have uncontrolled phosphate and you load with calcium, it takes 2 years to do what it takes 90 years in you and me. And finally, the last study is the landmark trial from Japan, where they show that if you compare standard phosphate control and a strict control, and you can see that over 12 months the lines diverge, that then you have much less additive change in coronary artery calcification. And they originally wanted to compare lanthanum and sucroferric oxyhydroxide, and you can see there's a trend, but it's not significant. So we now have many phosphate binders, but many patients don't like them. And I guess I'm not telling you anything new. This is the number one issue with phosphate binders. They constitute half of the tablet burden of a chronic dialysis patient. A typical patient has 19 tablets per day, which is one of the highest tablet burdens of all chronic illnesses. And half of that typically is a phosphate binder, ranging between 6 and 9, sometimes even 12 tablets per day, every day of their life. Why do patients not take them? An analysis in Wales, 25% report problems taking phosphate binders, 38% forget to take it at least once weekly. And the main reasons are, I forgot, they're too big in size, I have swallowing problems. We'll come back to this. That's a huge issue, dry mouth. There are too many, I have chewing problems, they don't taste well. And this is a really funny one. They're not effective, which is nonsense. If you take them, phosphate binders are effective by definition. Take-home message number 5. KDIGO now provides a stronger statement against calcium-containing phosphate binders. So all phosphate binders bind phosphate, but if you look at this, the good old aluminum is effective, low pill burden, but there may, and I'm stressing the may, there may be accumulation. Cost is very low. Calcium acetate and carbonate, high pill burden, accumulation of calcium. Sevelamer, high pill burden, pleiotropic effects. Initially, we were told this is a great drug because it binds cholesterol and lowers LDL cholesterol and uric acid. But we were not told that it also binds thyroxine, vitamin D, vitamin K, and others. Of course, sevelamer doesn't know what is good and bad. There's no accumulation, there's more cost. Lanthanum, there may be accumulation. It's an ongoing discussion. Cost is higher. Calcium, magnesium, you have a high pill burden. Calcium accumulates. Cholesterol is already off the market, at least in Europe. Now, KDIGO in 2017 said, we suggest restricting the dose of calcium-based phosphate binders in patients with CKD 3A and 5D. And in 2009, it had said, we suggest restricting the dose if there is calcification or adynamic bone disease or PTH continues to rise. And I had never understood this old guideline, because why would I wait for calcification to be established and then respond? Very clearly, calcification develops long before we can detect it. And very clearly, I want to prevent it rather than wait for it to occur and then restrict calcium-containing phosphate binders. But something we often forget, life expectancy. If my typical dialysis patient now is 75 plus, and you can see that the average life expectancy of that person is 1.5 years. I don't care about phosphate in that patient because most of them will have a low phosphate because they don't eat. I want them to eat. I want them to live. I want them to enjoy the last 1.5 years they have. And I don't care about calcification. I would be totally opposite in the young dialysis patient who I want to receive a kidney transplant. Here, I would do everything to prevent that patient from developing calcification or for calcifications to progress. And I think it's still ironic that we totally ignore this in the guideline. We also know new complications of existing phosphate binders. There are quite a few reports now on sevelamer-induced GI lesions. 19 cases, mostly in the GI mucosa, mostly in the gut, sometimes linked to GI bleeding, erosions, pseudo-inflammatory polyps. And if you were to analyze this reddish matter here, you would find solid sevelamer crystals in there. And this is how it looks like on endoscopy. And we need to educate our GI colleagues that this could be from a phosphate binder. Sevelamer can do that, lanthanum can do that as well. You either have these punctured deposits of lanthanum, and you can see here the lanthanum, the reddish areas, and clearly we need to tell our GI colleagues that they need to be aware of this in endoscopy. And everybody knows that if you're on lanthanum, you can check adherence by taking an X-ray of the abdomen. New iron-containing phosphate binders increase our therapeutic options. We have iron citrate, clearly a high pill burden. Pleiotropic effects, no. It does provide a lot of iron, up to the point, and there's a warning letter by the FDA that you can induce oral iron overload from ferric citrate. So you really need to monitor ferritin levels in these patients. And then we have sucroferric oxyhydroxide. I'm sorry, whoever came up with that name did not do a very kind job. Sucroferric oxyhydroxide is an interesting molecule because the iron is embedded in a starch matrix. So it's composed of iron, sucrose, starch, and water. And that is really important. The iron, of course, does bind the phosphate, but this whole composition is very important. First of all, the pill is large. It's like lanthanum carbonate, and compare this to aluminum, clearly it's much larger. But here comes the big difference with lanthanum. On a lazy Sunday, my son and I did a clinical trial. We stole one lanthanum tablet from the clinic and one sucroferric oxyhydroxide pill from the clinic. We put them in water. This is what happened 10 minutes later. Everything here has disintegrated. The moment it's in your mouth, it disintegrates. The lanthanum, in fact, to the dismay of my wife, was still sitting there after 3 days and hadn't dissolved at all. So you really, really have to chew this. And remember, many of our patients do have chewing problems. Many patients have dry mouth. So something that dissolves right away is certainly a good choice for these patients. And then we did a phase 3 trial for the approval of sucroferric oxyhydroxide over 52 weeks. They had a washout phase here, and we compared SFO against sevelamer. You can see that both are equally effective. When we looked at ferritin levels, there was a small increase with SFO, but there was also an increase with sevelamer, which is an artifact. Clearly, sevelamer doesn't donate iron. It happened to be all in the US because in the US they changed the reimbursement system, and all of a sudden, while the trial was ongoing, it was better reimbursed if you pushed iron IV in the US. And you can see that if you compare the EU and other countries, the sevelamer does not lead to an increase in ferritin, whereas sucroferric oxyhydroxide does, a modest increase. And this is the big distinguishing thing against ferric citrate. You cannot produce iron overload from SFO. It's a modest iron increase. And when we looked at this in more detail, it was almost exclusively those patients who were iron deficient to start out with, whereas the iron replete patients really had very little increase in serum ferritin. The big difference against sevelamer is pill burden. Grams per day, remember one pill is 500 milligrams. So this is 3 pills a day, the average daily dose, compared to sevelamer, which is clearly a much higher pill burden. And you can see that in the phase 3 trial, patients on average took 8 pills of sevelamer compared to 3.1 on average for SFO. Side effects. SFO does cause GI side effects, and the most important one is diarrhea. Almost every 4th patient. And it's kind of ironic to see that 16% of the investigators reported feces discolored. It should be 100%. Being a good investigator, I took a pill myself, and I can tell you, you have black stools for 2 days from just one pill. So it should be 100%. And clearly that doesn't happen with sevelamer. What does happen with sevelamer more frequently is nausea, vomiting, and in particular constipation. So some patients actually perceive the diarrhea as a benefit because if at all, as you and I know very well, patients on dialysis, if at all, are constipated. And diarrhea is really confined to the first 1 to 2 weeks. This is when the diarrhea episodes happen, and then it disappears. And in all likelihood, this is related to a change in the microbiome. We had a look at this. After 1 week, you see quite a change in the oral and intestinal microbiome, and this then disappears when the microbiome has adjusted to the iron load. What about GI bleeding events? Do you mask them? The Verify study looked at this. There were 40 GI bleeding events. For 36, no delay in GI bleeding diagnosis occurred. And in the other ones, there also was no big delay in workup. So despite the black stool, this terrible event seems to be recognizable. What SFO also does, it really prevents the formation of calciprotein particles, which is consider this the garbage truck. You and I, everybody, forms calcium phosphate crystals in the circulation. Then comes fetuin A. You build monomers. You build grade 1 calciprotein particles and then large calciprotein particles. And they are degraded in the reticuloendothelial system. And you can see that if you're on SFO as a dialysis patient, your capacity to form these particles really decreases, saying that you really prevent calcium phosphate crystal formation in the circulation. Take home message number 7. If you convert from any phosphate binder to SFO, you will have a better phosphate control. Here's a large study just published in 2019, where patients were switched from sevelamer, lanthanum, calcium acetate, and ferric citrate to SFO. And what you can see here, 3,000 patients, the patients with a serum phosphorus below 5.5 increased markedly. Same here, same there, same there. So it's a very uniform picture. And in all likelihood, this is related to simply patients taking their medication. In fact, if that study looked at medication possession ratio, you can see that it increased from 60% to 90%. So prescription refill rates increases because patients were taking their pills. This is a very objective measure of adherence, and that's a dramatic increase. Patients take this drug as opposed to many other phosphate binders. Let's go to very few real-world data. In Spain, you can see these patients were inadequately controlled or complained of a high pill burden. You switch them to SFO, phosphate goes down from 5.8 to 4.6. The number of tablets decreases from 6 to 2 tablets. And this is Spain. Spain is a funny country when it comes to eating. They have typically 5 meal times. They even have different names for the meal times. And essentially, if you live in Spain, you're always more or less eating. So if you can manage Spanish patients on this, that is a big achievement. Here's a few data from India. 94 patients. All patients were off phosphate binders for a week prior to SFO, and phosphate decreased from 7.6 to 5.1. Very rare AEs, most common AE diarrhea, no serious AEs in the study. So very similar data compared to the rest of the world. And finally, the most important message, SFO is effective as first line of therapy. Here's a study where patients with a dialysis vintage below 3 months or overall patients, new patients, were put on SFO. You can see that at baseline, their phosphate levels increased markedly, and then they decreased to 5.5 on average and stayed flat for the whole 1 year, with patients quite apparently taking their medication between 3 and 4 pills a day. So what did I say? I said that phosphate control is, and unfortunately it's still likely, beneficial. The source matters. Food additives are terrible. And I told you that high phosphate definitely accelerates calcification, in particular if you also have calcium around. Phosphate binders, the key problem is pill burden. We need to get away from 9, 12 pills per day. Calcium-containing phosphate binders, there's a stronger vote now against them. But as I said, if you have a 90-year-old patient, I wouldn't care. SFO is effective in phosphate binding as first and second line therapy. There's very rapid pill disintegration. There is low but definitive iron uptake, a low pill burden, high medication adherence. And I didn't show this to you. In contrast to sevelamer, there's no drug-drug interaction. for example, on active vitamin D analogs. That is it from me. Thank you for listening, and I'll happy to join the panel discussion.
Thank you so much, Professor Jürgen Flohr. It was an excellent talk about phosphorus and how to control phosphorus in CKD patients, especially dialysis. You have already summarized, so I don't have to summarize your talk. Yeah. So before I go to panelists, can I have a small question to Professor? See, in India, a small percentage of patients who are on dialysis, they have got severe, moderate to severe malnutrition and still have hyperphosphatemia. How do you recommend to proceed in such cases?
Well, it's very difficult for me because I'm not too familiar with Indian diets, and I guess there is no diet in India that's uniform because it's regional. So first of all, check their foods. Food additives, any phosphate additive is terrible when it comes to diet. So you can be severely malnourished, but the moment you eat phosphate additives, they're absorbed 100%. Some patients also generate phosphate from catabolism. So if they're really catabolic, their phosphate can, strangely enough, go up. So those would be my two most likely explanations.
Fair enough, fair enough. Let's go to the panelists. We have got about how much time? We have got about 30 minutes. So let's start with the panel discussion. And Professor, you can also chip in whenever you have a comment to add on to the panelists. So my first question is, any of those two panelists can take this question, and I'm not in particularly asking anyone, but we'll restrict to one panelist only because of shortage of time. And later on, if we can have comments from other panelists as well. So what I ask is, what is your first choice of phosphate binder in Indian patients for treatment of hyperphosphatemia? Why? And also, as you know that the Indian study, especially from South India, we see that dialysis patients have about 66% patients have hypocalcemia as well. And some of these patients have calcium below 8 milligrams per deciliter. So do you have any decision in changing your first line therapy in such patients? So please go ahead.
So can I start?
Yes, please. Yes, please.
So basically, I see different types of patients in my chamber. In ESI patient, they are basically from the low socioeconomic patients, and in my private practice, they are from the high socioeconomic. In the low socioeconomic in Indian diet, it is not very much rich of protein intake or phosphate containing diet. So for them, what my usual finding is that low calcium, low to normal calcium, and phosphate is not much high. So in those patients where the calcium is little bit low and phosphate is not much high, so my first preference will be definitely calcium containing phosphate binder. And also on dialysis patient, which sometimes see there is low calcium. So definitely low calcium helps us to guide whether we choose from the calcium containing or non-calcium containing. Now to the other part, that is the high socioeconomic condition, basically from the urban population who eat Western type of diet with lot of food additives, cokes, etc. So they have very high phosphate capacity. So we have to definitely take the non-calcium containing phosphate binder. Sevelamer is a good choice, but the problem is that the pill burden to achieve the goal, phosphate goal, you have to give for 800 milligrams, sometimes thrice daily or sometimes 4 times daily. Then also we cannot achieve the phosphate goal. So in that scenario, this newer molecule SO will be very helpful. And in my practice, I have seen maximum 2 tablets is enough. We don't have to go to the 3 tablets, and sometimes in the follow-up period, only 1 tablet is sufficient to control the phosphate level in those group of patients.
Professor, whenever we go to international conferences, we hear that whatever the calcium level is, you should not actually be giving calcium-based phosphate binders. What is your comment? Because in Indian population, some data shows 60+% of patients having hypocalcemia. They are asymptomatic otherwise.
So if there's true hypocalcemia, i.e. not malnutrition and not low albumin, if ionized calcium is low, in the past we have argued that you can tolerate this as long as it's not excessive. So an ionized calcium below 0.8 millimoles per liter, that is when I start to worry, but a modest one, I don't. Now, that pendulum is swinging a little back. We had set this under the impression of the EVOLVE study, where I've published a paper on hypocalcemia after the initiation of a calcimimetic. You do induce kind of a slow, hungry bone syndrome when you start a calcimimetic, and it was quite asymptomatic. We had no problems really. But now the feel is that maybe in that instance, it makes sense to provide a little calcium if the bone recalcifies. So the one big thing to look at in that scenario of hypocalcemia is PTH. What is your PTH? And what is the dynamic of your PTH? And that should really govern what you do. If you have adynamic bone and you have low calcium, which happens rarely, I wouldn't substitute it because that calcium will not go to the bone, it will go elsewhere. And the most likely place is vascular system.
Thank you so much. Actually, my second question to the other panelists is very related. So my question was, does PTH or hyperparathyroidism, number one, number two, pre-existing cardiovascular disease, and number three, age of the patients affect your decision in selection of phosphate binder? I think partly Professor has already answered this, but I want this to be repeated for the sake of audience's understanding. Do we select phosphate binders based on these three: PTH, cardiovascular disease, and age of the patients? Yes, Dr. Nair?
Thank you, Dr. Tarun, for that question. Yeah, absolutely. Absolutely. All these three factors are taken into consideration before I start the patient on any phosphate binder for that matter. Because if you have a low PTH in patients having an adynamic bone disease, calcium-based phosphate binders is going to add to the problem. Of course, we are always concerned about vascular calcification and coronary events in elderly patients. So if the patient is elderly and patient is having an adynamic bone, especially diabetic patients, adynamic bone disease is quite common. So if the PTH is inappropriately low and there is evidence of adynamic bone disease otherwise, usually I will not start the patient on, even though the calcium is borderline. As the professor said, I may not start the patient on a calcium-based phosphate binder. So definitely there is a reservation to start on calcium-based phosphate binders for situations. But having said that, in India, we know that cost is a major problem. So to start off, practically in most of the situations, it is calcium-based phosphate binder only, especially when you consider the cost. Otherwise, if you ask me from the scientific perspective, yes, we'll avoid calcium-based phosphate binders in this scenario.
What about the age of the patient? Professor did mention in his talk. So do you select based on the age? So somebody younger as compared to the older population?
Well, I mean, first of all, most of my really old patients, and for me, old is 75 plus. Most of them don't, you know, the definition of old, it's your own age plus 5. So it's, most of them don't have a high phosphate because they eat this much food in a day. But in young patients, I worry a lot. And in young patients, and we've really learned something about sevelamer. Sevelamer can bind phosphate nicely if you take it. But sevelamer does a second thing. Sevelamer decreases your vitamin K levels. And in particular, the vitamin K2, which we all need to inhibit vascular calcification. So sevelamer is a double-edged sword in a way. And we've shown that if you supplement vitamin K1, you can nicely reduce and even prevent progression of calcification. Now, if you take that together with sevelamer, you offset the whole effect. SFO doesn't do that. Sucroferric oxyhydroxide doesn't do anything to the vitamin K system. And it clearly is a very effective phosphate binder. But I guess the consensus is the best phosphate binder is the one which is taken.
Yeah. Professor Nair, do you agree with Professor? And the other thing is, honestly, I mean, we are used to using sevelamer because it came first. Do you use SFO as a first-line treatment in all your patients, or you still go by sevelamer?
Yeah, I
Well,
actually,
not all- sorry. Go ahead, please.
yeah, please go ahead. I'll answer after you.
I mean, my patients are really distinguished. If they have very modest hyperphosphatemia and they're oldish and they would like just a little bit of a pill, SFO is possibly even too potent. In all my young patients, I start this as first line. But I, of course, live in a kind of blessed world where cost is not so much of an issue. It's an issue, but not the biggest issue.
And you, Nair, Professor Nair?
Yeah, a few patients have tried myself as a first line, especially where the cost is not an issue, and especially in the situation with CKD stage maybe 3 or 4 when the phosphorus is going up. As discussed earlier, even one SFO will help. Will take care of.
So when you talk about cost, Professor, if you compare sevelamer versus SFO, I think SFO will be cheaper because
Exactly.
the burden will be lower, isn't it?
Exactly, absolutely. If you compare on a maybe a pill to pill or a milligram to milligram or a
Right.
weight to weight basis, SFO scores over sevelamer. Actually, if you're giving sevelamer, at least you have to give 400 milligram, 2 tablets at least 3 times a day. So whenever I think of controlling phosphorus, I usually I don't add SFO to sevelamer. I take off sevelamer and give them, because that will add to the pill burden if you add on in patients with resistant hyperphosphatemia.
Yeah, sorry to
So
interrupt. Practically seeing, if you see prescriptions of 100 nephrologists and they have non-calcium based phosphate binders, still sevelamer outscores SFO despite that it is more efficacious, the pill burden is low, and the cost eventually is lower. Why do you think this is still, despite that the product is available in India for more than 3 years now?
probably by convention, most of the nephrologists are actually used to using sevelamer. That is why probably over a period of time
needs to be changed. Anyway, let's move to Dr. Jayanto Datta.
Yeah, so I have used quite a lot of SFO in my patients. The main thing to continue is the patient compliance. So because of this black stool, so it is 100%. As Professor says, it is 100% patient complaining of the black stool. And if they are not counseled properly, they stop this molecule of their own because of this black stool, and they are thinking there is GI bleed or something like that. So this is very important for discontinuation of SFO in this patient. And number 2, of course, this molecule, though it is in the market for quite a few years, I think the science behind it and the efficacy behind it is not known to the all nephrologists, and we are used to prescribe sevelamer. So because it is our pain habit and it's a new molecule, so we need more some scientific session or awareness amongst us in the Indian nephrologists to prescribe this molecule, and also the patient counseling part.
Right. So, Dr. Datta, another question to you is, what about the combination of phosphate binders in Indian population? Because there are studies also published in various journals where they have tried combination of phosphate binders and they have achieved reasonably good result. And specifically why I'm asking and why I'm telling you in Indian context is we have discussed, both of you have, as a panelist, have raised the issue of cost. So what about combining, say, for example, a small dose of calcium based and then SFO and likewise? So do you have any experience, or what would you recommend?
Yeah, so combination of calcium containing phosphate binder, if the patient is grossly hypocalcemic, low calcium, the calcium level is low, and also the gross level of hyperphosphatemic. So I have combined in a few patients, and in the subsequent time when the calcium level achieved, calcium level is normal, I have stopped the calcium containing phosphate binder and continue with the SO. But I have not used sevelamer carbonate and the sucralfate together. So I have not any experience of combining these two molecules. I have few patients who are both on calcium containing and non-calcium containing phosphate binder to correct the calcium level vis-a-vis the correct the hyperphosphatemia.
Professor
Actually, I echo the same thing. Actually, I start some patients on monotherapy with SFO. And once the patient is having significant hyperphosphatemia not controlled with sevelamer, most likely it is due to the adherence and pill burden issues. So switching from sevelamer to SFO actually works well. So that is my experience. I have not combined sevelamer with SFO.
SFO.
Right. Professor Flo, any comments about combination of phosphate binders?
Yeah, see, with SFO, I don't think it makes a lot of sense. I clearly realize that for cost constraints, you may consider this. But if you only need to take, and a typical German patient has 3 meals a day, and a typical German patient can remember take one pill per meal. Now, sometimes I try to explain to my patients, maybe adapt your pills to what you're eating. Maybe you can get away with 1 calcium at noon or so, but most of the patients, this is too much of an advanced concept to really adapt the phosphate binders to whatever they're eating. So I find it much easier to just tell them take 1 pill per meal, full stop.
Great. And so I think briefly, one of the panelists did mention, but still let me ask, this is the question, or this is the problem when the patient comes back to our OPD clinic, and what is the most common reported adverse effect of SFO? And how do you manage that? Do you withdraw the drug, re-challenge it? How do you manage it? Dr. Datta and Dr. Nair, whoever wants to take this. For me, it is GI diarrhea, and then they are not happy chewing the tablet because of the taste, probably. They are unable to eat their food. That's what they complain. So do you face this kind of a situation, and how do you manage it?
Yeah, I'll take that question first.
Yep.
Some people complain of significant bloating. They are unable to take food, and after the and even after after stopping that, they break for 1 or 2 days and they themselves restart, and they were comfortable breaking the drug for a week, and while restarting it is happening again. So such patients, probably I will not insist to go back to the thing. Exceptionally, some patients have complaints of diarrhea also, but more often we see that the patients are symptomatic when they have polypharmacy even otherwise. If the pill burden of other drugs are much more, patients are on significant antihypertensives, patients are significant other supplements, then probably diuretics. Then adding SFO sometimes can be a problem. Generally, the pill burden is not that, but especially in early stages of CKD, if start on 1 SFO, patient tolerates very well. Patient is on dialysis and the patient has other multiple comorbidities. Patient has malnutrition, patient has cachexia, patient has features of inflammation. Then the GI tolerance has a significant correlation with that. So I'm actually, to be very frank with you, I'm fairly comfortable using SFO in pre-dialysis patients because they tolerate the drug very well. In dialysis patients, of course, the phosphorus is not getting controlled. I withdraw sevelamer, put the patient on SFO, and most of the patients tolerate well. Few patients complain of diarrhea, and as Dr. Datta rightly said, we have to warn them regarding the discoloration of stools. Then there is no problem. Once you start the drug, straight away you say that this is likely to happen, but don't worry about it. Else they will stop without informing us. And I do agree, very vehemently vehemently try to argue that pill burden and adherence is probably to cut the long story short, where SFO scores over other drugs.
Yeah, even Professor Flo did show the evidence that after 1 week, the incidence of diarrhea starts coming down. So we have to just counsel the patient that you have to probably bear this for a few days, and after that, the gut may stabilize. Any other?
I think the most important thing is that you warn your patient this will happen or this may happen. So I always tell my patient, hey, expect a few days or weeks of loose stools. Most patients really have loose stools rather than overt diarrhea. And I warn them, hey, your teeth may be brown and you can simply brush it away. If patients know that, they are much more likely to stay on the pill and get rid of the diarrhea as a self-limited complication.
Yep. So another question is, how significant is the concern around iron accumulation with SFO? And do you recommend any monitoring strategies to look into this aspect?
Absolutely not.
Absolutely no, yeah. Iron overload is not at all an issue. because if you look through the discussion also, the absorption of iron, actually the iron compound is actually practically insoluble in the gut. So the whatever absorption is happening is always very minimal. And I don't change my routine strategy of checking the iron status every 3 months in dialysis patients. SFO on or off does not make a difference for me.
Yeah, so I generally check serum ferritin and iron on patient on dialysis every 6 months, whether they are taking SFO or not. Or this is a protocol for management of anemia. So that's the part. But for SFO, we have to do iron study. It is compulsory. It is not like that. It's a part of our treatment protocol. Every 6 months, we do serum iron and ferritin who are on dialysis and on IV iron and erythropoietin. So it is a part of routine practice. But for SFO, nothing special.
Right. There was another question, though we all professor and all the panelists have discussed that SFO can be used as a first-line therapy. But any of you, do you think that certain subset of patients will benefit more with SFO and we should try to put them on SFO as compared to any other phosphate binders? Or everyone is equal?
Well, let's say you are iron deficient. The iron uptake is low, but then clearly I would love something that puts in a little bit of iron. You have a patient who has a high pill burden. You have a patient who you definitely want the pill to take. You have a constipated patient, and most of my patients, as I said, are constipated because we tell them don't drink so much. So that is quite a lot of patients already where I would consider this as first line.
And to me, some patient, basically the good quality of dialysis is also a good measure to control hyperphosphatemia. Sometimes some patients were not very eager for 3 per week or 12 hours dialysis in a week. So sometimes they are very reluctant, basically those on chronic interstitial nephritis where there is a good amount of urine output. So they basically take once weekly or twice weekly hemodialysis. And for them, the phosphate burden is really a problem because they are not achieving this weekly KT/V. So for them, hyperphosphatemia is more compared to the patients who are taking a good quality of dialysis. So for them, I usually prescribe SFO as a monotherapy, whom I think they may not continue as I prescribe. So for them, I usually prescribe SFO as a monotherapy.
So before I summarize, any comments from any of the three professors that we might not have touched upon while in view of controlling the phosphate in CKD patients? Any final comments before I summarize? Nothing. So I think it was an excellent talk and excellent discussion about management of hyperphosphatemia. Professor did mention the association of phosphorus with morbidity and mortality and possible improvement in morbidity with control of phosphorus, and the phosphate control can be achieved through diet. So definite non-use of processed foods where 100% absorption he mentioned will be there. And I would also like to add in, there is a difference between animal-based protein where phosphate are more absorbed as compared to plant-based. So if it is possible, then switch over to plant-based phosphates, proteins, and then obviously adding in the phosphate binders will help. And I think I'll hand over back to Genova, Dr. Preeti, to give a comment and then wrap up today's session.
Yeah, thank you so much, sir. First and foremost, on behalf of Genova, I would like to extend our heartfelt gratitude to our international faculty, Professor Floch, who have shared the expertise and research in the hyperphosphatemia and the CKD with such a clarity and the depth. I also like to extend my thanks and gratitude towards our moderator, Dr. Tarun Jaloka sir, and our panelist, Dr. Rajesh Nair sir, and Dr. Jayanta Datta sir, for leading the panel discussion and encouraging the thoughtful dialogue during the discussion. I would also like to thank all the delegates who have joined the meeting. So once again, thank you so much joining with us for today's meeting. So thank you.
Thank you. Goodbye.
Good night. Good night.
Thank you. Bye-bye.